We're here to hear Mary's story and to explore what happened during her life and to consider the role of the agencies involved with Mary and her family. We're also going to reflect a little on how agencies work together to support Mary and her brother, and to discuss the learning that came out of the review, both during it and on analysis and reflection afterwards. And then at the end of the session, we'll explore the recommendations that were made and what they might mean for you as individuals in your own practice, as much as what they might mean for the whole system. Next slide, please. So, Mary. Mary was a young girl who died in 2018, so it is some time ago now. She was 13 when she died, and she died from a very severe asthma attack. Now, this followed the death of her brother, John, who also died 7 years earlier from a cardiac arrest, also from a severe asthma attack. And to date of the review, although I haven't double checked since then, there are no known similar incidents of 2 asthma-related deaths of children in the same family anywhere in the UK. To remove any doubt, Mary's death was likely to have been from sudden and acute asthma attack on top of chronic undertreated asthma. So her death was of a result of a chronic illness. Next slide, please. Mary's family were complicated, I think is the best way of describing it. There were 4 children. The oldest girl provided very significant care to Mary herself when she was younger, after John's death, when Mary's mother was really in a very bad place. And Mary's older brother was a very stable and important part of Mary's care in the latter parts of her short life. Her brother's death was a very traumatic event and had a very significant impact on mother's ability to parent at the time, although there were a number of issues about mother's personality and her parenting style and the constitution of the family, which made her parenting sometimes less than optimum. There was an incredibly acrimonious split between Mary's parents, and then there were some very complex new relationships on both sides, with Mary's mother moving into a challenging lesbian relationship and a subsequent further lesbian relationship, and Mary's father moving to live with someone who herself had lost a child in an accident which had been the subject of a serious case review. There were major inter and intrafamilial tensions and fallings out across the family. So at different parts of the history of Mary's life, different members of the family were either in or outside the circle and not speaking. Many parental disputes and differential claims on Mary's attention, and very different lifestyles between Mary's father and his partner and Mary's mother and brother at home. Next slide, please. Now, there are a lot of agencies involved on and off and had contact and ongoing involvement with both children. Both children had asthma, so the NHS was very significantly involved, several different services. There was clearly the local GP service, and Mary and her mother lived, certainly for the earlier part of her life, in a village, and was from a village on the outskirts of Ipswich, from a very well-known village family. So the GPs were involved, health visiting, all the normal services, and of course the NHS in terms of asthma services, asthma support, and the hospital for their various hospitalisations. Mary's primary school and secondary school were involved at different times. There was family support services and social services in and out, and towards the latter end of Mary's life, Kafkas were involved as well. There were never immediate risk of harm concerns about Mary, or John for that matter, but there were constant rumbling underlying concerns about neglectful care and constant rumbling concerns about the management of Mary's asthma. And there were concerns about the home environment during the periods Mary was living with her mother and at one point her brother. So, next slide, please. Thank you. Now, her family and her home. Her father's home was when he moved out of Mary's life into a new home with his new partner. Very tidy, very well structured, very routinized, quite strict rules and strong expectations. Her mother's home was a complete contrast. The family structure I've just described. But various adults came and went, various different relationships with Mary's parents came and went, various tensions. And Mary, from quite a young age, was used to people moving in and out, moving house, and so on and so forth. But her home environment was at best still not optimum. Don't know if anybody knows what those creatures are on the screen, but they are sugar gliders, which is one of the many animals that were in the house that Mary grew up in with her mother. And there were constant, continual pets coming and going, dogs, sugar gliders, and other animals in the house. So there's quite a high level of, the usual pet fur, etc. Her mother also smoked quite heavily, and the house was very smoky, although we were constantly assured by Mary's mother that they smoked outside. And Mary was given a fair amount of independence and stood on her own 2 feet in terms of her own care as she grew older, making her own meals, choosing when she went out, obviously with some permission. So when she was with her mother, she lived a fairly laissez-faire lifestyle. When she was with her father, it was quite structured. That's how it goes. And so John and Mary too grew up in this household where the environment was not conducive to good management of asthma. And that was an underlying theme right the way through. Mary's mother was very articulate, was well known, had a big personality, has a big personality, can be very, very convincing about what she's doing and how she's caring for her daughter, is very insightful about the trauma of John's death and the impact it had on her parenting, but also tended to use that traumatic emotional upheaval as a barrier to changing her lifestyle and to generating quite a lot of empathy and sympathy for her and herself. And she was, genuinely, it was a huge trauma in her life, as it would be. But one of the puzzles of the review, and continues to be a puzzle, is how and why she, after John's death, did not manage as assertively as needed to be managed the way in which Mary's asthma medication was managed, overseen, overviewed, and monitored. And that was a very big theme right the way through Mary's life, particularly in terms of contact with the NHS. Life was not always easy at home, it is fair to say. She had a lot of independence. And as I say, her older sister when she was little, and then her older brother were frequently the people that gave her routine and care and support. One of the difficulties of understanding Mary's life is that her voice in the records is largely missing, unfortunately. Her schools, both schools, were very involved with Mary's life and provided what looks like to have been very significant emotional support, but that was not always discussed with other people or recorded or considered in the light of the broader family context. So the schools, the primary school were very good at liaising with other agencies. The secondary school tended to look inwards and supported Mary as a young teenager. Her clinical records demonstrated that the communication was primarily between her parents or the adults accompanying her to her appointments, very rarely directly with Mary herself. So they didn't talk to her when she got older about her treatment and about how she was managing her treatment and why she relied on the reliever medications rather than the maintenance medications that she had been prescribed. So on and off, there were very high usages of the prescription that she had for when she was beginning to get breathless that gave her immediate relief. But the preventer treatment, which is actually the more important treatment in asthma, I'm sure the clinicians will correct me if I'm wrong, but that was not administered and monitored in a steady and steadfast way as it should have been. And nobody discussed it with Mary directly. It was mediated through the adults with her. And her views were certainly sought in relation to her move to her father and then back home, and that had a significant influence on decision making. But that didn't extend to conversations about the rest of her life and her management of her asthma. And the assessments showed a very varied degree of engagement with Mary and indeed John about their own life experience, what it was like living at home, what they wanted, what they wished for, what was good, what wasn't. And then finally, Mary's own experience of her family life was of being able to dissemble and to put forward a picture of family life which was positive. And there is no doubt that Mary had very strong emotional ties and links, was loved and loved her family members despite the tumultuous emotional environment that she could be in. Next slide, please. So I'm going to take you through the story of her life. It is in the report, but I'm going to summarise it as we go, and I'm going to give you some of the comments about what the review found about that life. From January to November 2010, the agencies who had contact with John and Mary were primarily the primary school, the GP, and West Suffolk Hospital. Mary's physical care was poor, her practical care was poor, and her mum regularly smelt of alcohol are some of the records, but no referrals were made during that period. John attended accident and emergency and had several GP attendances. There were issues around follow-up appointments and was not brought and non-attendance at clinics. Mary was taken to the hospital in October of 2010 for a clinic appointment, and her mother gave the paediatrician inaccurate information about the number of courses of steroids Mary had had over the year, which is another picture of Mary's mother constantly downplaying the clinical presentation. But the concerns weren't serious enough to justify, in the opinion of those seeing them, Mary's referral, and the GP practice was very, very assiduous, and it was assiduous all the way through Mary's life in trying to follow up requests for appointments, was not brought, tenacious chasing Mary's mother and carers up, and very tenacious attempts to get engagement. And, you know, 2 or 3 attempts, mother would engage, Mary would be taken, and then the pattern would start again. But at that time, there was no indication that there were asthma management plans in place for either child. And the practitioner's concerns about overuse of the reliever inhaler, right the way back to November 10, was not assertively pursued. And that pattern continued right the way through the review. John died suddenly from a cardiac arrest on Mary's 6th birthday party. There was a SUDIC, and the SUDIC meeting heard that conditions were bordering on the neglectful, and the police felt that conditions needed to be addressed. So the SUDIC chair suggested that there might need to be a child in need referral made, and recommendations were made from the SUDIC. But the action plan wasn't clear about who should make that referral. A follow-up SUDIC meeting continued to discuss the poor physical home conditions, number of pets and types of pets, the level of cigarette smoke, Mary's mother's non-compliance with the treatment and monitoring requirements. But in neither meeting was there actually a formal referral to children's social care about the concerns. Referral was made for an asthma review, and there was follow-up through child in need services. But the degree of concern didn't trigger a formal referral. During that period after John's death, between January and July, child in need services were involved. There was some really good practice. Mary's mother and her new partner, Mary's father and new partner's history was identified at that point as a potential risk because of the review relation to father's partner's serious case review issues. And there were allegations being made between mother and father about the parental care of Mary. Pattern continued with the was not brought, but there was tenacious and good intervention through family child in need support services, and the approach was treated originally as child in need and then stepped down to a team around a child. The 2 key episodes really, one is the focus during the initial period on the home conditions and the neglectful care without really understanding or being informed about the relevance of Mary's asthma and the nature of her home life in terms of her care. And the second was that as home conditions improved, social care stepped back, and the link wasn't made between neglectful care, her home conditions improved, but her treatment compliance did not. So there wasn't a holistic approach. The team around the child began in July 2011. Concerns continued to be expressed by NHS staff about Mary's asthma treatment and the way she was managing her asthma. And there was a bit of a drama around mother's request for a nebulizer, in that mother and Mary's older brother both felt that having had the nebulizer removed is as inadequate at John's death, because John had one. The family were very upset by this, but there was no clinical justification or need for a nebulizer. This wasn't seen in context of the wider context. It was very context specific. So when those decisions and discussions were happening, consideration wasn't given by any of the professionals involved as to why there was this strong family preference for a nebulizer, or why they weren't accepting and agreeing with the clinical view. the comment in the report, and I think it stands, is that in a family where compliance is already an issue and they're not accepting and following medical advice, no matter how clinically sound it is, that sort of conversation needs to be thought about in the wider context. There were ongoing concerns at school about Mary's child protection matters and welfare concerns, and lots of discussion about it. During the team around the child period, there was a referral. Initial assessment began and was concluded after a home visit. Mother presented very well. Mother said that Mary was well, and told the assessor that Mary hadn't visited the GP, which was not consistent with the GP referral. There was a very limited initial assessment, didn't interrogate what was known, didn't look at the broader picture, focused on the primary reason for the referral, which was the maladministration of medicine, rather than looking at the family's history, the previous concerns, or indeed the context. So the early help system and family support services, who really understood the service, the context for Mary, and the social care service didn't actually communicate during this. They didn't talk to each other, and the records couldn't easily at the time be accessed by professionals. So the judgments were made on a very limited picture. There was a missed opportunity at this point to really identify what Mary's life was like. She'd had a burn caused by filling the baby's bottle from a kettle. This was in relation to her half-brother, to make the bottle. At 8, she was feeding her baby brother, and that should have really given rise to a much more curious approach. Moving through to the next set of concerns, those were 2013 concerns. Sorry, am I out of sync? I am out of sync. 2013, there were concerns. 2014, there was an asthma-related incident. In fact, there were several. Between January and September, there were several incidents, including a call out to the ambulance and admissions to hospital. And there were also, at the same time, a number of referrals to the police in relation to domestic violence incidents at the home between Mum and her ex-partner Aileen over access to Mary's half-brother, Justin. The significance of these wasn't identified, and links weren't made to the previous history. And Mary herself was demonstrating distress and emotional upset at times. She told the school nurse at a drop-in that she was unhappy at home. And that was dealt with directly with Mary in school, and it wasn't communicated to other agencies or professionals. By November, however, there was a referral made by Mary's paternal grandmother, which included the information that Mary was unhappy at home and that her physical care and home environment were both very poor. Her paternal grandmother was concerned that Mary's mother wasn't taking Mary to appointments, and the response to this referral was very thorough. It was a good assessment. History and context were reviewed, weaknesses in the previous initial assessments were identified, Mary's views were sought. It's the one time that they really were sought. So were father's, and a full comprehensive assessment began. And during that period, unsuccessful attempts were made to engage with Mary's mother, and an incident at school took place when mother didn't respond to a request to collect Mary. And when she did respond and arrive, she shouted at Mary. A home visit took place at the social worker, and Mary's mother was told very clearly and very assertively to improve the home environment. And this assessment actually identified, it's the only place where the links were properly made, that There was a real risk of Mary's asthma deteriorating because of the poor compliance and management, and recognised that this was potentially fatal, and acknowledged that in the circumstances of the trauma of her son's death, it was odd that Mary's mother was not responding to this. The recommendation was a child in need plan, and a meeting was planned. It was a good piece of work. And child in need plan meeting began. Mary's father attended, but Mary's mother didn't. And her father was both insightful and concerned and very measured about the situation. In that child in need meeting, there was a suggestion that he should take Mary home from school that evening to live with him, given the level of concern that was identified about home life at Mum's home at that point. And the meeting decided to support Dad's decision to do that at the end of the meeting. And social care wrote a letter supporting Father's decision, but making it clear that it was Father's under his parental responsibility. He was legally able to do it, and it was a private matter between both parents. Social care agreed to remain involved, but voluntarily. This was actually, in practice terms, a sensible decision by Father, and a pragmatic decision by their child in need meeting, was completely defensible legally. And the letter itself was clear, but both mother and father thought and continue to believe that it was a decision made by children's social care as part of their powers. And again, they felt that social care had the power, but social care's continued involvement in Mary's life was right, but it was done voluntarily with no statutory decisions. Mary settled initially very well at home with her dad and her stepmother, his new partner, and her half-brother from that relationship. And Father behaved very appropriately in terms of care and in attention to Mary's needs. There was lots of positive stuff. Mary was happy at home, and a decision was made to close the case as the actions identified in the assessment were addressed. There was then an incident where a referral was made by Mary's brother Peter, saying that Mary was at risk of harm at Father's because he'd been violent towards Mary's brother Peter, this is her older brother, and that Mary was unhappy. And Peter was given advice that it was a private law matter and that social care would not intervene. A few months later, in August, Mary's father made a referral to children's social care because Mary had gone on a voluntary agreement with mother to live at home with Mum and refused to return to her father's home because she was unhappy about Father's partner's attitude towards her. His concerns were appropriate and well pitched and had validity. He was advised as a consequence of that referral to make an immediate legal application to resolve the matter through private law. Children's social care decided that if there was no order made, they would undertake a new statutory assessment, and they informed CAFCAS that the matter was a family matter. So this complicated all the approaches that were being taken. The closure of the case after Mary's move to Father didn't give consideration about the risks that might occur if mother wanted back. There was no contingency planning in the event that she did return back to a neglectful home situation. It was system focused, the whole approach, and it didn't give due weight to the context and the history and the issues in that really good assessment that identified the concerns. And the complexity of considering it was a private family matter wasn't informed by this history. The common assessment was completed by September. Mary was asked her views, but not in an in-depth way at this point. And the assessment didn't include any discussion about or analysis of the impact on Mary of the pets at home, which was still there, the cigarette smoke at home that was still there, and the assessment didn't include lots of contributions from the secondary school or from the GP and hospital in terms of what they knew about the circumstances at home. And father's concerns were downplayed and interpreted as part of the dynamic between father and mother, and the case was closed. Whilst this was not immediately relevant to Mary's subsequent death a few years later, it was a very significant piece of learning about the incredible importance of understanding context and history. And Kafkas's involvement was limited to the way in which they are involved in private law. There was communication between Kafkas and social care, but the depth of knowledge and the history of Mary's life was not fed into that consideration in a way that would have been helpful. But Mary did express a wish to stay with her mother, and so she remained where she was. And to be fair, the fact that Mary's older brother had moved back into the home, that home conditions were cleaner, the house had been decorated, Mary was getting more consistent care from her brother, did influence some of that. And from November 2015 to 2018, there was no referral back to social services because of what appeared to be significant improvements at home in her home life. What wasn't picked up was in April 2016, Mary had a week away in Lourdes with her school, and her health improved significantly because her medication monitoring and management was being done by the staff. The significance of this, that wasn't picked up. And there was overall an improvement in her asthma control and use of her emergency reliever rather than her maintenance treatment. But the ongoing pattern of missed appointments and continued lack of response to GP and clinic requests didn't change. There was a period of poor control for a short period in late 2016, and mother was again firmly and clearly told about the link between pets, cigarette smoke and uncontrolled asthma. And she was reminded that Mary shouldn't rely on her reliever inhaler. And it was really interesting in our engagement during the review with mother and with older brother, they both really significantly downplayed the existence of the pets in the household. And so, they're pets with non-allergenic allergenic fur, or they don't shed. There were lots and lots of reasons why it couldn't have been that was affecting Mary. The family disputes continued, and the school was very supportive of Mary during that period, but they didn't share their concerns. But she unfortunately had a very severe asthma attack after being out for the day on the 15th of February 2018, leading to her death. The home visit after that, a home visit and assessment by GP was clear that Mary before that was happy and healthy, and whilst not ideal, the home conditions were suitable. So all in all, at that point, her death was both a surprise and a shock, and because she died from natural causes, there was no inquest. But at that point, the NHS did call a review. Can we move to the next slide, please? So the NHS commissioned a specialist review because of the fact that there were no known two child deaths in one family, and that came to a series of conclusions which indicated that it would be appropriate to undertake a serious case review, which was then commissioned. Okay, sorry, I'm just shifting papers here. You can hear me doing it. Okay. That review identified that there were some very, very significant patterns of missed appointments, additional reminders, acute healthcare episodes and attendances, and a consistent and continual pattern of non-attendance and repeat requests for appointments. The findings of that review were that there were a degree of concern about chronic neglect, concerns about mothers' ability to accept, implement and comply with advice in relation to complex healthcare needs, and concerns about how effectively the different agencies work together. And it posed 5 questions which informed the serious case review process. So the serious case review looked at those questions. They were the level of professional curiosity and challenge, whether they were effective interventions or referrals, whether information was shared effectively, did partners allow the complexity of the family arrangements to distract them, distract professionals from the safety of the children, and did professionals support the parents to meet the needs of the children. As part of that review, we had a learning event, and I think many of you on this call were part of that. It was a very constructive and helpful event. We looked at what went well and what did not go so well. And in summary, the participants, most of whom had been very closely involved with this case, and with Mary and her family, felt what went well was that there was really constant and tenacious and proactive reminders to Mum about missed appointments right the way through both John and Mary's life. So Mary got to her appointments after 3 or 4 reminders, but that reduced alertness and prevented escalation of concerns, and it raises questions, particularly I think for the NHS system, about when is enough enough, regardless of short-term changes in behaviour. Because people got anxious, Mary and her mum showed up, everybody breathed a sigh of relief and went back to how it went. And so the very tenacity was both commendable, but also prevented curiosity. What also went well was the concerns identified at the first SUDIC meeting, but of course they were not communicated clearly enough, particularly around asthma management, to social care. So the post-SUDIC assessments and interventions focused on part of the problem rather than the whole of the problem. What went very well was a very good assessment by a social worker after the concerns resulted in referrals prior to Mary's move to her father, which did identify and conclude that mother was a significant risk. There was very good support at both schools with oversight of her medication, but they didn't understand or question her reliance on her reliever rather than her preventer. She often turned up with just the reliever and didn't take the preventer when it needed to be taken. Very good levels of information exchange between the GP practice and the community paediatrician, but it was very much about the facts and the maintaining attendance. It was focused on the key issue for those clinicians rather than what's going on in this family. Why have we got this pattern? How, what else is happening that needs to be thought about in terms of Mary's own life and life experience? and they certainly didn't question the impact of such a long-term pattern of concern. School nursing was used really well by Mary at her secondary school, and she got very good emotional support at the school, but again, it was contained within that context rather than communicated effectively or questioned in terms of the wider picture, and didn't focus enough on asthma management, perhaps. I think the other thing that went well is that Alice appeared, Mary's mum, verbally very articulate, open and willing to listen and engage, and often cooperative and reflective, and very traumatised by John's death and keen to look after Mary's well-being. And she frequently improved after challenge, but that diverted attention to her resistance to actually accepting advice and reduced the level of concern. So professionals again didn't see the longer picture and the pattern. And of course, she lived in a home where she had good relationships, despite the dynamics and the fallings in and out. She had consistency in care and oversight of her management from her older brother for a significant number of years. But again, that diverted attention from her mother's parental role and influence within that household. So much of the work of professionals, the learning event thought, was, if seen in isolation, well within good and reasonable standards. But professionals recognised this was frequently meant that the wider history and the focus was diluted or diverted. So it's a right irony, really, isn't it, that the good practice diverted from a longer term effective set of interventions. What didn't go well enough was some of the things we've mentioned, but also Mary's life, it was just about good enough most of the time. So things didn't get to the point of thinking that there was a need for multi-agency safeguarding discussions. And I guess one of the things the learning event explored at some length was that safeguarding was an issue, even if the statutory thresholds for protection were not met. But the system wasn't recognising the need not to focus on have we passed a threshold, but to focus on what's going on for Mary and her family, and is it good enough, and when is enough enough? And the referrals themselves didn't generate effective statutory action apart from the one time with a really good one assessment. The importance of the history, the context and the patterns, rather than the incident triggering the referral, was not understood well enough. Information exchange was what was happening rather than good communication. People weren't nuancing that information exchange or questioning it or collaborating with each other or reflecting on what was happening as a multi-agency system or between multi-agency partners. Relevant information wasn't shared across the system, and there was very limited use of chronologies whenever incidents arose, which limited the ability of people to take into account the history and the context and the patterns. And when information was shared and plans were made, there wasn't enough weight placed on the follow-through and the monitoring of the actions, the decisions, or the sustainability of any plan. And plan Bs were not created. And one of the things I think that was a learning point was that when you have a plan, sorry, I'll just turn that off. When you have a plan, you need a plan B as well. The whole issue about engaging with Mary herself was a really significant thing that didn't go so well. And of course, there was the issue of engaging with Alice, Mary's mother. People kept her on board, tried to be friendly, were desperately sympathetic with good cause because she was traumatised, but she was not challenged. And when she was challenged, she just absented herself and walked away, but that wasn't seen as a risk factor. So people tended to cut her more slack than perhaps was helpful. I took a long time on that because the learning event was very significant in our understanding. So can we move to the next slide, please? Thank you. The overall findings, Mary's life was not as good as it could have been. We had good practice. People had tenacity with attendance. There was good input with family support and early help. She did get bereavement support. There was some very good skilled social work, and the recording in and of itself was good. But there were 4 key points where practice could have been better. After the SUDIC, the limited assessments and responses in 2013, the approach to Mary's move to her father and then back to her mother, and the insistence on it being a private law matter. So we explored in our analysis 4 themes: professional curiosity and challenge, information sharing and communication, referrals and interventions, and family complexity. Okay. Professional curiosity and challenge was quite a significant issue, really. I think I've covered it a fair bit in summarising it, but people challenged or questioned incidents or specific focus points or specific areas of concern, but rarely did they say, but what else is happening? What's life like for Mary? Mary, what's life like for you? How can we make, how can we help you with your asthma better, etc., etc. Now, clearly her condition was chronically undertreated, as found at the end, so there had been a long history of her not using her maintenance medication effectively. That in itself was a concern, but that in the wider context would have been a wider concern, and those questions of Mary's life were not brilliant. And the other issue around professional curiosity is that whole thing about what neglect actually is, and a degree of focus on practical evidence of neglectful care rather than the subtler stuff around things like her mother's ability to block, who is actually caring for her, how is she managing her own medication, how you talk to Mary herself. So overall, the analysis indicated there wasn't enough professional curiosity or challenge, and the tendency was to take a very narrow focus on the presenting issues and concerns rather than seek to answer some fundamental questions about Mary's mother's parenting capacity and ability. In terms of information sharing and good communication, as I said, the records were good and people communicated frequently bilaterally, but they communicated about an issue rather than the wider context. So the overall view was that, in short, lots of information was exchanged, but it wasn't shared, interrogated, or its importance understood. The professionals took different perspectives out of the same facts, and each agency had a piece of the jigsaw and a perspective, but the exchange between professionals about each other's view wasn't effective enough, as was the lack of confidence to actually say, well, we don't understand why this is important or why that is important. So the importance that was wholly understood by the clinicians, the medical professions about asthma management, weren't fully grasped by social care professionals or the school, and the fact that asthma is potentially fatal wasn't fully grasped either. So in considering neglect, the home conditions were considered, but not necessarily the medication management, not because they didn't know about it, but the understanding of why that was important wasn't shared clearly enough. In terms of intervention and referrals, I think you'll have picked up from the summary of Mary's life that there were periods of very good and very helpful interventions, but some much weaker practice as well. And the focus on threshold detracted from the focus on context and history. There were some very limited assessments and very narrow assessments, and the risk that Mary's mother posed to Mary on an ongoing basis wasn't clearly identified by most professionals, although it was in one instance. So the review felt that information exchange was good, but information understanding wasn't as good. And the referrals that were made were appropriate, but the need to understand that referral in a wider context was limited. And then family complexity. I think there are 2 short paragraphs on this in the report, but it was again a rumbling underlying theme, was that the family was very contentious. There are lots of continuous, cross-level allegations, counter-allegations. It's almost a postmodern family in that one family's truth was another family's lies. There was huge allocation of blame, no acceptance at all of responsibility for what was happening in terms of Mary's life, because it was always blamed on the other partner, and that diverted professionals away from Mary's own life and experience. It was a very adversarial situation. It was challenging for professionals to deal with, and people tended to focus on letting the adults get on with the blame game rather than questioning and being assertive about challenging what was actually going on from their own perspective as professionals. So, next slide, please. We concluded that John and Mary's death were neither of them predicted and both were unexpected, that there was lots of hard work put in meeting Mary's healthcare needs, but nobody was really sufficiently curious or saw things from Mary's perspective or talked to each other. Interventions were issue-based, time-limited, and the cumulative evidence wasn't considered. And overall, for all professionals, practice was too narrow in scope and in focus. Next slide, please. So there are some key areas of learning, and those key areas of learning were in terms of the approach to long-term conditions for Mary and for John, some learning around assertive practice and the way in which professionals need to be supported to be assertive in complex situations and not to be diverted, and professional recognition of safeguarding concerns. Next slide, please. I'm going to leave you to reflect on that. We've been talking for, well, I've been talking for nearly an hour. That's knackering for all of us. So I'm going to suggest that you reflect on what you've heard over a cup of coffee. We take 10 minutes or so. So if you could all be back at 20 to 11, I'd be really grateful. And then we can ask some questions and think about it and talk about it at that point. Is that okay with everybody?
Yes,
you happy with that, Tracy? Happy with that?
Yes, that's fine. Thanks, Jane. Thank you. Yes, that's great.
Back in 20 minutes, 10 minutes.
10, yeah.
Tracy, I can see your emails on the screen.
Sorry, oh bugger, can you? Right, sorry, thanks.
Yeah, you might just want to stop sharing your screen for a bit.
I need to stop sharing, yeah. Thank you for that tip. Can you see them now? Oh, she's gone.
No, you're all okay now.
Right, thank you. Yep.
Tracy, it's Michelle. It could have been the epic data breach of all time there.
I know.
Needless to, or could have actually compromised your personal and professional relationships.
Luckily, it was just saying somebody got into the event.
Yeah, I saw. I know. We can't see them now.
Good. Oh.
Thanks, Tracy.
I'm just trying to get it onto the slideshow.
Mhm.
Is that up? It's up as it was, isn't it? Yeah.
No, it's not. It's still on the screen. You can still see the screen bars.
Oh, it doesn't always come up as slideshow underneath. Okay, let's try it again. Right, this should be it. That's it, isn't it?
It is indeed. Perfect.
Yeah, great.
Thank you. Give people another 2-3 minutes to come back in.
Yeah.
Somebody's waiting. The problem with everybody being switched off is I have no idea who's all back.
No, I know, and I can't see anybody. I can't see anything beyond this screen. So
Yeah.
Could you raise your hand if you're back at the screen, please? We'll use that function
Yeah.
way of checking how many people
Oh,
are back.
lovely. That's what I like to see. A whole load of hands all peering back up. Thanks, Howard. Still some to come. We're about half there. Thanks, JC. You're back. $19 people. It's coming in the count.
Sorry, were we putting our hands up to say we're back?
Yeah. Yes,
Okay.
please. Just so I know. Thank you. Keep putting your hands up as you arrive. Probably about 3/4 back. You put your hands up when you arrive, please. Lovely. Right. I think we've probably got the majority of people back, so I'm conscious of how precious time is. So if you could pop your hands down, that would be a real help. Just go back and take it back down so that we don't have legacy hands around the place. Can we move to the next
slide?
Oh.
Yep.
Okay. Now this is the point where hands become very important, because this is the point for you to ask me questions of what you've heard in that first hour. But before we do that, I just wanted to ask if anybody who's in on the event and was on the panel wants to add anything to what I have said. No? Okay. Any questions? Thanks very much, Ali. Any questions from people? There is no such thing as a stupid question, and on reflecting about this, when I was looking at it again a year and a half on from doing it, one of the things I want to say really strongly is nobody did anything wrong. Not anybody did anything wrong. It was more learning about how you practice than about things that went wrong in this system in any way at all. So just to be absolutely clear that it was one of those reviews where we learned a lot about practice, but there weren't trigger incidents that could have turned the tide, as it were. So, questions? I have one hand up, I think. Let's go up. Yes, Anne.
Hello, Jane.
Hi.
I'm probably going to ask quite a contentious question.
Good.
And it's necessarily how I think all the time. But we see these learning events with great frequency. We see the same messages with great frequency. So there must be some disconnect between that we're not exploring as to why actually this analysis and practice issues still continue. They're always going to arise because that's human nature.
Mm-hmm.
Do you think that organisations, practice needs to look at the actual requirement or that the employers require of staff and their employees, and this best practice all the time, which is in direct, and the difficulties come, and people will say, you know, I didn't have time to do it, or I didn't think. Actually, we don't have enough time to be able to sit and reflect properly on a regular basis for in many cases. And I don't think we actually put that out there, and we do say it, we go, oh, we haven't got enough time, but actually we don't recognise that getting on the treadmill, doing the things over and over again because we've got so many things coming in, actually impedes reflection, analysis, meaning for the child.
Yes, and I think you've asked a very important and a very real question. As a reviewer, what I would say is, of course, that's an issue. And I think it is a major issue. And I think it's at 3 levels. I think it's an issue for the leadership of systems. It's an issue for the management of the system. But I also think it's an issue for individuals.
Yeah.
And I think I would ask the same question of individuals is it easier to focus on your system and your process and your rules than to say, hang on a minute, I want to stop and think here. It is easier to be busy. Is it easier to be busy than to stop and think about how I'm doing this job? So it's at all 3 levels is my view as a reviewer. Now, the solutions, of course, sit firmly back into the system. There was no evidence in this review that volume of work, shortage of staff, etc., directly affected practice. I hasten to add, this is not a review where I concluded that these things happened because people weren't being supervised, they didn't have time, their caseloads were too big, there weren't enough people. So that actually is a bit of an underpinner to your question. It wasn't one of those. The practice was the practice in normal to good conditions for practitioners, not in extremis in any way. Which hence the importance of individual and managerial responsibility. But the responsibility for helping people to do that does sit firmly within the way in which the system collectively and individually supports people to take that reflective approach to practice and those questioning ways of being professionals. And that, of course, I would revert back to saying is your lead managers.
Thank you.
Alison.
Sorry, I just took myself on. Yeah, really leading on from that. Perhaps there needs to be some sort of overarching advice then, and maybe searching regularly for our, was not broughts, and having a multidisciplinary discussion about it. So bringing it sort of higher up so that more agencies can talk together and make a plan, and with time, protected time for reflection.
Absolutely.
We're all going to have very many of these cases.
Yeah, and I think some of the recommendations in the report, which we'll come to at the end of the discussion or after the questions, focused on some of the ways in which was not brought policies work.
Thank you.
Any other questions or comments at this stage?
Jane, I've got one. I can't put my hand up, so it's Tracy, because I can't see anything other than the slides. Sorry, I just can't. It's just on. It's all up.
It's how it works. Yes, I know.
Yeah, that's right. Yeah. I just wanted to ask about the professional curiosity that was the lack of that was found in the case, and because it's happening, and we know it happens quite a lot in case reviews, and we've got a number of cases currently where we've got the same kind of issue around professional curiosity and challenge, and I just wondered what your view was on how we can get around that, really, how we can improve that for staff.
Yeah, absolutely. I was musing on that while I was making my cup of coffee, actually, because of course it bobs up all the time. I think I would love every member of staff in every profession that's involved in the lives of children and families, and indeed in the lives of adults, to have a card which sort of flashes up in front of their head every time they look at something, which is, what on earth's going on here? What do we know about what's been going on historically, and who knows what? Who's involved? And therefore, how do I approach this from that context rather than a direct context of what's happening in front of my very eyes? What's the issue? So if we had a card with the 4 big questions on it that everybody carried around, that was dinned into people at the beginning of their professional lives, dinned into them during their training, dinned into them during their supervisions, and it's constantly repeated, is, well, what do you think is happening? What do you think the issues really are? Not, oh, I know this is this, we have to do this is this, she isn't doing that. So it's that sort of ability to stop yourself right at the beginning of starting, if that makes sense.
It does, yeah.
Rob.
Hiya, I was just interested in how we can minimise that risk of that kind of lost in translation when we're sharing health concerns with social care.
Yeah. It's interesting, isn't it? Have you any ideas yourself about how it would work better or could work better?
I suppose from experience, I think raising those concerns and being really clear about what we mean by kind of health needs not being met and consequences of that. I think that's been helpful in the past. I guess too, just kind of that trying to break down some of those barriers of kind of language, really, and how we talk about risk. Absolutely.
It's my favourite one in a meeting, and I still do a bit of practice, but it's in a different field now, is I don't understand what you mean. Can you just explain that to me? Why is that an issue? And having the professional confidence to do that is important as well, isn't it? So that you don't sit on your, I'm a social worker, so I need to look knowledgeable. I'm a health visitor, so I need to look knowledgeable. I'm a doctor and I know exactly what this means, but I don't understand why that's important. And being able to have those conversations rather than just what are we looking at and what are we going to do about it? Does that make sense?
Yeah, that's great. Thank you.
Yeah. Okay. Any other questions or comments at this point? No other hands. It's not an unfamiliar case, really. In fact, actually, it's almost an archetypal. These are the sorts of things that happen quite a lot in cases. What it hasn't got is the big trigger incidents and the big missed opportunities. And I guess that's why it's so rich for the learning, really, because we're not looking at what went wrong. We are looking at how we practice in this review. So we went on to a set of recommendations because we were looking at how we practice. And I guess having the conversations about the case was as important during the review process as the end of the process and the conclusions for those of us involved. hence why it's important today, because what we're doing is talking about those everyday matters of how do we do our jobs better, learning from what people did in this situation. The recommendations were relatively short, and they addressed the 4 themes. And one recommendation is the learning is distributed widely. So this is part of that process. There are 4 key themes, and those key themes occur in case after case. So the approach to long-term conditions. We recommended that all health recordings evidence that every missed appointment matters holistically. So set out in the notes how historical information has been utilised to help form the next actions to be taken. So, you know, a note was not brought. This is the 3rd in 5. This is what we're going to do next. That NHS partners work together in Suffolk to develop a new protocol and pathway for managing non-compliance when children have asthma. And we were quite strongly clear that that would be helpful, so that there's a pathway that people really understood. And the public health team develop an awareness raising campaign in relation to the risks associated with asthma. Because one of the things that came out from just the conversations, which is not in the review, but came out quite strongly, was that the importance of managing asthma was not fully understood in terms of, and if you don't, you can die, because asthma is seen as such a common childhood condition that it's a bit like, well, I can't think of other ones, but so instead of seeing it as a potentially fatal condition that needs assertive, consistent management, it's seen as this child's got asthma, make sure they have their inhalers. And I think that's a really important issue. And that's a really important issue to talk about, to understand, for professionals to understand, but for families and schools to understand. And to be confident about asking the questions in a way that wouldn't have happened before. And I think we've seen that shift with diabetes and childhood diabetes, and people are much better informed now about the importance of it. So we need that shift in childhood asthma as well. And then we suggested that partners put together a series of what I would call light bite sessions, you know, 1 hour over lunch with a cup of coffee type training events for the multi-agency workforce, talking about the relationship of long-term chronic and potentially harmful conditions, poor management and neglect, because poor management of long-term conditions by a parent is neglectful practice, neglectful parenting. And understanding that is part of, you know, a referral pathway. This is an evidence of poor parenting. This is neglectful. This builds up to a picture. Is quite important, because I'm not sure that people really understood that. So that was the approach to long-term conditions. The recommendations in terms of assertive practice were in relation to some practical things to do, because of course learning to be assertive with, to put it bluntly, parents who are extremely good at convincing, manipulation and emotional management of the professionals in front of them. Mary's mother was very good at choosing when to cry when I interviewed her. Sadly, I'm a hard-bitten old social worker, so I'm afraid I just gave her a hanky and kept going. And being assertive is something you can only learn through doing, but there's some recommendations to help. One is that protocols for responding to parental disputes when there is a history of concerns are developed to avoid what I called the default position of it's a private law matter. And it is very challenging in practice to work with a very conflicted and adversarial parental situation where everybody's chucking blame around all the time. And it is easier to default to, well, they're all as bad as each other and she's not really at risk, so it's a private law matter. That default is not a healthy place to be, and it probably doesn't happen a huge amount of time, but it can have a significant impact on a child's life experience, as it did for Mary. We recommended that supervisors both focus on and audit the degree of assertive practice evidenced by practitioners in a case, and ensure that staff are properly supported and skilled up and trained and challenged in terms of their learning and their skills and their practice with challenging, avoiding, engaging, dominant, emotionally volatile or plausible parents and carers. And I have to say that Mary's mother exhibited all of those characteristics. That young people assist the partnership to develop a tool to use with practitioners in professions with less face-to-face contact with children and young people. And I felt very strongly about this, that it's so much easier to talk to the adults as a clinician, and that young people themselves will be the best people to help develop a tool to train us all up, me included, to remember that when you're seeing someone, even when they were 7 or 8 or 9, talking directly to them is a much better way of engaging and eliciting information than communicating through their parent, even if you then have to translate it into the, and this is what you as the adult need to do about it. So we recommended that that happened, and we felt that this tool would help adults to do it. And how does information get to targets? Somebody's asked. Do you want to put your hand up and interrupt me so that I know who you are, CB? Or just reply? What are you actually asking about?
Sorry, Jane, I was just actually just commenting on, I was reflecting on something that you had said earlier, that we were talking about earlier, and the fact that a campaign or information is gone, and I was just talking about how who are we targeting with our information, and actually if we are to target the parents who we think are at greater risk of mismanaging the asthma, how do we actually get that information to them? Is the public health campaign towards staff, or how do we educate communities on and how do we educate them adequately and for them to really understand? And
absolutely, and I think those are really good questions. Public health professionals are really good at answering some of those questions, because that's part of the public health role, which is how do you differentiate a piece of information to different target audiences. And hopefully these, Howard can probably correct me, but the action plan coming out of this should include some work with public health about a universal campaign, targeted campaigns for professionals, targeted campaigns for parents, and identification of particular tools and methods to use with resistant parents or parents who have communication challenges, can't read or have learning difficulties. So, you know, that's the sort of thing that needs to be thought about. It's not just a blanket one-off. It needs to be thought about as quite a complex project, in my mind, but then I'm not the person that will be responsible for making it happen, sadly. As a reviewer, you happily make your review recommendations and step back, but I think it's something to think about. And light bites, you know, short sessions in environments are really important. Somebody else has, I'm loving this. Jodie, you've said with a paediatric background, talking to the child always comes first. Indeed, it does. And it was very upsetting that there was so little communication with Mary herself. I couldn't agree more. And it's, you know, it was very hard in the review to get any sense of Mary as a person other than mediated through other people. Her voice wasn't there. Now, that's not to say that people didn't talk to her, and they certainly did in the school, but how that it was fed into the understanding of her life when professionals were intervening was very not clear. And clearly the clinical records all show that the communication in the main was with Mary's caring adult, whoever turned up, and it wasn't always mother, it wasn't always father. Mary's mother's first female partner took her quite a lot to appointments at one point. Okay, so where was I? Back to the assertive stuff. If I had a different hat on, I would be seizing on recommendation 3 of developing a tool with young people to work with adults about how you communicate with them in certain settings would be lovely. The third set of recommendations related to the interagency system, and it's an old chestnut, and it's one that challenges us all, but the issue of chronologies in recording. The actual recording itself on files wasn't bad, but there was no running chronology that allowed people in pressurized jobs, when they first get a piece of information, to flick back and say, let's have a quick flick at what's been going on here. In many of the professions, so the use of chronologies across professionals and the opportunities there might be to develop integrated chronologies was discussed at length at the learning event, and I think it is important. I don't underestimate just how challenging it is for organisations, and certainly at this time it would be sitting on the would be lovely, but we have more high priority things to be dealing with. But it is a really important message that when you first pick up a file, you need to be able to see the story before you decide what needs to happen. We recommended that social care examines the implications of this review for the way in which common assessment, single assessment and comprehensive assessment processes introduces better approaches to utilising contextual and historical information. The way in which it's structured doesn't facilitate asking those important questions of history, context, what's been going on, how long it's been going on. So that was the other recommendation. We recommended that the MASH always asks referrers for context, history and repeat behaviour information when discussing referrals, so that the MASH is moving from an incident focused to a context focused approach to assessing what's coming in, and that they develop ways to ensure multi-agency information is properly distributed and accessible to other agencies when decisions have been made. And that the NHS considers how best to improve communication between separate NHS specialisms and services, and how they move from an information-based, which is a cultural norm, exchange, to communication, reflection and discussion-based practice. And finally, I suggested that a desktop aid memoir be produced for all frontline staff about searching for, recognising and analysing patterns and repeat behaviours when evaluating how well children are being safeguarded and their welfare is promoted. So those were the recommendations that I made. Final slide is thank you very much. It's very nice going back to young person Mary and revisiting it, and it was very nice to be able to have a chance to talk to you all. I'm very fond of Suffolk. I happen to live here, but I am also very fond of Suffolk now, the work you're all doing, and I think you do a very, very good job. So it was a pleasure to be able to come and contribute to that. So look after yourselves, stay very safe. I hope everything else goes well, and I'll no doubt be in touch with Howard and Tracy afterwards. See you soon. Bye-bye.
And Jane, can we just say thank you to you and thank you to everyone for coming along this morning. I hope you found the session useful. I know it has been for me. I'm sure it will be for lots of other people as well.
Mm-hmm. Okay. Thanks. Take care. See you all soon.
Thank you.
Bye.
Bye.
Thank you.